Welcome back to Neurology 101 here on the ProPA podcast. I'm Dr. G, and today we're concluding our other encephalopathy series with one of the most common and reversible forms of global brain dysfunction, toxic metabolic encephalopathy, or TME for short. If you've been on hospital rotations, you've definitely seen this, even if you didn't call it by name. Did you know that toxic metabolic encephalopathy accounts for more than half of all cases of altered mental status in hospitalized patients? It's not a disease, it's a syndrome, and the brain is its usual victim, not the source of the problem. In elderly patients, even something like a UTI or a change in medication can trigger it. So let's look at the kinder patho. What is toxic metabolic encephalopathy? Well, TME is a diffuse brain dysfunction caused by non structural systemic insults, including metabolic derangements like hypoglycemia, hyponatremia, or uremia, organ failure like liver, kidney, or lung, medications like sedatives, opioids, and anticholinergics, infections, and electrolyte imbalances. These factors impair neuronal function and neurotransmission, causing delirium, confusion, and in severe cases, coma. All right, now let's look at the clinical presentation. Usually, we have acute or fluctuating confusion, inattention, disorganized thinking, sleep wake cycle disruption, agitation or hypoactivity, and tremors or asterixis in some metabolic causes, like hepatic or uremic. There are no focal neurologic deficits. This is a diffuse brain dysfunction. A key point is TME is often reversible once the underlying issue is corrected. How do we make the diagnosis? Well, this is a clinical diagnosis of exclusion. We want to get lab work including a BMP to look at electrolytes and glucose, LFTs to look at ammonia for hepatic encephalopathy, ABG if acid-base disturbances are suspected, a BUN and creatinine for uremia, a tox screen and a medication review, a CBC and a urinalysis to evaluate for infection, and vitamin levels like B12 or thiamine. Imaging. We can get a CT or an MRI, but it should be normal or show nonspecific changes. An EEG might show diffuse slowing without seizure activity. An LP, if concerns for CNS infection, can be performed. How do we treat it? Well, we got to fix the underlying problem. We need to correct electrolytes, treat infections, discontinue or adjust medications, support renal or hepatic function, and consider dialysis for severe uremia. Some other supportive care measures include reorientation, sleep hygiene. We want to avoid unnecessary restraints or sedation, and address sensory deficits like hearing aids or glasses. Prognosis is good if identified and corrected early. Now let's look at the book med versus the street med. Book med. TME is caused by reversible ischemic issues. Correct the imbalance and the encephalopathy resolves. Street med will have the confused 85-year-old with a UTI and 5 new meds isn't just old. They have a brain screaming for help. Review their meds, get labs, treat the source, and stop blaming age for what is really delirium. Some quick clinical pearls. Always think systemic, not central in TME. An EEG shows diffuse slowing, not focal spikes. Rule out other causes like stroke, infection, or seizure. Confusion is a vital sign in elderly patients. Even small triggers like Benadryl or constipation can unmask TME. All right, it's time to practice our knowledge. So, a 72-year-old woman is admitted with confusion and lethargy. She was recently started on oxycodone for her hip pain. Labs reveal mild hypercapnia. Which of the following is the most likely diagnosis? Is it A, ischemic stroke, B, TME due to opioid use, C, Wernicke encephalopathy, or D, Alzheimer's dementia? If you said B, TME due to opioid use, you are correct. Remember, medications are common and reversible causes of TME, especially sedatives or opioids in the elderly population. Which EEG finding is most consistent with toxic metabolic encephalopathy? Is it A, sharp spikes in the temporal region, B, triphasic waves, C, diffuse background slowing, or D, burst suppression? If you said C, diffuse background slowing, you are correct. An EEG in TME shows generalized slowing without epileptiform activity. Triphasic waves may be seen in hepatic encephalopathy specifically. Okay, so some final thoughts. Toxic metabolic encephalopathy reminds us that the brain is often the first organ to show signs of systemic trouble. Learn to recognize it early. Your patients will thank you for saving their mind and not just their labs. Next time, we'll start our movement disorders and cranial nerve syndromes, starting with essential tremor. If you've ever had a confused patient on your floor and weren't sure where to start, this episode was for you. Share it with your study group or hospital crew. And remember, this is the Pro PA podcast, where future pros in medicine are made. Catch you in the next one.